by 15 now. So thank you very much for this response, this kind of response. It gives us motivation to conduct this more frequently. We'll be hoping more, possibly we'll be hosting this in the near future more frequently. Now, I would like to invite our HOD sir, Dr. G.P. Kaushal sir, to the dais. Thank you, HOD sir, for giving us the opportunity to conduct this COCEPP-2024 in Baba Saheb Ambedkar Hospital. I would like to invite Dr. Gaurav Thakre sir, Head of Office, Dr. Baba Saheb Ambedkar Hospital. Thank you, sir, giving our time, valuable time to this COCEPP-2024. Now I would like to invite Dr. Sunil Gomber, who is the pioneer and founder of COCEPP-2024. Sir, please join us the dais. And Dr. Ajay Gupta sir has recently joined us. Kindly give up a lot of applause. And thank you, sir, for your valuable time to the COCEPP-2024. I request Dr. Tanu to present a bouquet to Dr. G.P. Kaushal sir. I request Dr. Komal to present a bouquet to our AMS Ajay Gupta sir. I request Dr. Vaishnavi to present a bouquet to Dr. Gaurav sir. I request Dr. Anushka is here. Dr. Anushka will present a bouquet to Gomber sir.
You know, I postgraduated in first year, then I left UCMS. Now she is again following it.
Now I would like also invite our faculty, Dr. Anita ma'am, Dr. Eden ma'am, who is also faculty of COCEPP-2024, Dr. Mugdha ma'am, and our external faculty, Dr. Manas Kalra sir. Kalra sir, please join us the dais. Dr. Tanu, please present a bouquet to Dr. Manas Kalra sir. Now I would like to invite Dr. Sunil Gomber sir for the brief introduction about the COCEPP and the further course of this COCEPP-2024. Sir, please join us the dais. Thank you.
Good morning, everybody. Well, I welcome all the delegates. I never thought I will be able to do the COCEPP again. This is nothing but a clinical examination in pediatrics, which people have forgotten. People have always been harping on the investigations, irrational investigations, and increasing the cost of the patient. So this is, I still remember, I read an article in BMJ. This is what a literature has come. It was mentioned that this art of clinical examination has almost died. It has been buried. And I am from that era that when I still remember, I can name them, I was very fond of, I'm very privileged, my boss was Dr. M.P. Gupta. I had my thesis in cardiology. He was Dr. M.P. Gupta from G.V. Pant Hospital. I am from that era when there was not ECO has just started. And ECO was only M mode, not even 2D. And he used to examine, he used to say, इसका ये सीवियरिटी हो सकती है, ये हो सकता है, इसको MS, MR, AR है. आप खड़े खड़े देखते रहे, how is he saying this? And I also try to learn those art, but now unfortunately I tried my level best to start, and I started this COCEPP in 2003, if I remember, in UCMS. And since then I have been going on and on. And I said at the outset, I never knew that whether I will be able to do it here or not. But I am very fortunate that having joined this department and Dr. Kaushal and other administrative staff helped me. I was asking the other day Dr. Ajay Gupta, who is our AMS, कि सर मेरे को ना एक COCEPP करना है और मैं डिजास्टर वार्ड में करना चाहता हूँ। तो सर का पहला था बिल्कुल यू आर वेलकम, आप करिए। हाँ डिजास्टर वार्ड है, इट इज ए डिजास्टर वार्ड एक्चुअली, सो इट इज ए डिजास्टर वार्ड। लेकिन उनका कहना था भी अगर डेंगू आ गया या कुछ और आ गया तो आपको कुछ खाली करना पड़ेगा। मैंने कहा ठीक है, वील डू दैट, बट यस आई हैव बीन वेरी हैप्पी, बट यस इट हैज नॉट, लास्ट बट नॉट द लीस्ट, this COCEPP would not have been possible without you people having an overwhelming response. So I must congratulate you, because that is why I am able to do this program. Thank you very much. I now welcome Dr. Kaushal, who will be addressing me from the department side regarding few words about COCEPP.
Good morning. At the outset, I welcome you all from department size, that today on rainy day you have made it possible. As Dr. Nagra was telling, we really got very overwhelming response to this. We just imagined that 30 people should join us so that we are able to start it at least in BSA. And here I will also say that, sir, thank you very much. With Dr. Gomber, this COCEPP has shifted from UCMS to BSA hospital. And thank you very much, sir. And today I think 50 enrollments are there. If I'm not wrong, another 20-30 have been refused for this. And venue, I will definitely agree, it's little congested one, but I think whatever discussion will be, it will be really nice discussions. And as sir said, this very art is going down and down in view of so many investigations available within a very short turnaround time. You are able to clinch the diagnosis. But there are places where such investigations are not available, or are available at a very far off distance, or at that too at a very high cost. There these things do matter. And definitely history and examination, if you do it in a very systematic way, that definitely makes you reach very near the diagnosis. And just to confirm your possibility, you have to do very little investigations. I think you must agree with me. But because that art is really going down, time is short, so much of rush in OPD, we just write investigation, prescription and that. उसी में खिचड़ी पक जाती है, this word I am using, and sometimes everything changes and you clinch the diagnosis much later as it would have been on the first or the second visit in your OPD or in doctor. So with this I would again thank all of you, and including Dr. Ajay and Dr. Thakre, who have made it possible. Thank you very much, sir. Without your support, it's not possible to conduct such a program in disaster ward, when once it is almost declared that any day patients will be there in this room. So thank you very much, sir. And I again welcome you all. Please keep your mind open, learn the things. Sometimes things do help. If anything uttered today, within a fraction of a second it comes once you are appearing in Viva or in your exam, that really helps. So try to learn maximum from today, and we will continue this program in the future also. Thank you very much. Just for one thing, I invite Dr. Ajay Gupta for word of blessings, and again thank you very much for allowing us to conduct this program. He himself is head of department ENT, so core clinician by default. We got such post administration and all. So sir, please.
Thank you, sir, for the kind words. At the outset, I would say I am a postgraduate from GDB Hospital, and Dr. Gomber was professor at that time. And my very dear friend Anil Rolia, he was one of the postgraduates. I used to meet him, and occasionally sir also. Dr. Kaushal has been a guiding force, and I've learned a lot from him, especially administration. And regarding COCEPP, I think the art of examination is really dying down. I don't know how many undergraduates, it starts from undergraduation. How many undergraduates read Hutchison or Kedas? I think that in the first year, second year, we were told to read only Hutchison and Kedas. And if we know Hachi, we used to call it Hachi. If we read Hachi and Kedas, the undergraduation was clear. There was no issue passing undergraduates, especially the major subjects. So that is so important. And as Gomber sir has said, we had a professor in medicine. He used to say, okay, what is the murmur? So pan-systolic murmur, mid-diastolic murmurs, S1, S2. सुनने में हमें बहुत टाइम लगता था, but the diagnosis used to be there. And once after the advent of echo, as an example, the art of listening to murmurs has died down. Similarly, the other things have gone down. And this concept of COCEPP is so important for us doctors because not everywhere all the investigations are available. So the examination and the history comes into being. So I congratulate Department of Pediatrics for the same and wish success to this program. Thank you so much.
Because today we have come for learning, just to cut it short, I invite the dignitary, said Dr. Thakre, thanks, kar diya maine. So thank you very much for sparing time with us, said Dr. Thakre. And I invite the dignitaries for lamp lighting, sir. This is going to be a brief ceremony. Dr. Nagar, please. Neeraj, yeah. Lamp lighting, sir. Thank you.
Thank you very much. I welcome Dr. Manan Kalra, whom I am associated with him for very long. He is a doyen of, I should say now, pediatric oncology. So what best I thought that I will bring this. We have two cases. Actually, I thought of having two cases. Now he has to leave early. So what we are splitting into two. So oncology case will be done by Jeevan. He is from Rajiv Gandhi Cancer Hospital. And what I have done again, there are two cases actually. One is a case which is an acute case of leukemia. That patient hasn't come, but he will tell you the history. But then to make it more interesting, I brought another case who is already on maintenance therapy of the chemotherapeutics. So we just show you that. Dr. Manas Kalra.
Thank you, sir. It's a big honor to be here. And, to come and interact with the young minds is always good. It keeps you active and agile. So, thank you, Kaushal sir, Gomber sir, for having me here. So, Jeevan, over to you now.
Good morning, everyone. First of all, I would like to thank Dr. Sunil Gomber sir, Dr. Kaushal sir, and Dr. Manas Kalra sir for giving me the opportunity to present the case here. To begin with, the informant is the mother. This is the 14-year-old male child, Shubman Singh, who is the resident from the Lakhimpur, from Uttar Pradesh, who comes with complaints of easy fatigability from past 15 days, paleness of the skin from past 10 to 15 days. With this only the complaints, the history of presenting illness. The 14-year-old boy, apparently healthy 15 days back, then complaints of easy fatigability, which was incident in onset, not progressive nature, not associated with any giddiness or headache, and not disturbing his any daily activities. After few days, the parents noticed that parents and one of his relatives noticed that the child was having the child was looking paler when compared to the other siblings and one of his friends. And there was no history of any cough or any puffiness of the face or any swelling of the lower limb. Mother also gives the history that the child had fever before admission 7 days back. The fever was only for 2 to 3 days, which was low grade, intermediate in nature, not associated with chips and dryness, and we were not taking medication. With this history of presenting illness, I would like to tell about the negative history. There is no history of any loss of weight or loss of appetite. There is no history of any limb pain or limb swelling. There is no history of any jaundice or high color urine. There is no history of any hematuria. There is no history of any blood transfusion. There is no history of any rashes. There is no history of any bleeding manifestation. For these above complaints, the child was consulted with the nearby medical practitioner. We advised some blood test. As the blood reports were abnormal, child was referred to the IS center.
Why have you taken any history? What is the negative history? I always ask, why have you taken this negative history?
Yes.
Now he should tell me. He has taken so many negative history, alteration in urine color, etc. Now why have you taken all these histories?
Because child was having
Having fever.
Yes, sir. Child initially mainly easy fatigability, paleness, and fever, which were only for 2 to 3 days.
Up to that, negative history.
Yes.
Can you elaborate on the negative history and why you have taken that history?
As the child had given the history of paler, I would like to ask about the severity of the paler, whether the child is mild, moderate, or severe paler. So I would like to ask about the puffiness of the face to look for the congestive part failure symptoms and any swelling in the lower limb.
Okay, what else? In that history, basically you are trying to approach anemia in this child. This child has fatigability and this child has anemia, and this has developed over a period of 15 days. So it's a fairly acute history. It's not a long history. So we are dealing with some acute problem. That much is clear, okay? So now he's trying to see for this acute anemia history, what all other possibilities can be there. So now please tell the negative history, and as sir said, we will rule out one thing in one go. Yeah.
So first I would like to ask about the severity of anemia. For this thing, I would like to ask about the puffiness of the face to look for any signature symptoms and any lower limb swelling. Then I would like to ask about any history of jaundice or any eye color urine to look for any signs of the hemolysis.
Okay, so if there is sudden onset anemia and if there is high colored urine, what is your differential at that point of time? If somebody tells that is what we are asking. You are asking this negative history for which disorder?
Mainly the generalized weakness and the paler to rule out any infectious causes as
What infectious cause will cause color, increase color of the urine or change the color of the urine?
Malaria, bleeding for what?
Malaria per se will cause
black water fever.
Black water fever in malaria. Hemoglobinuria can cause high colored
You
urine.
have to be very specific.
Yes.
What else?
And history of jaundice or eye color urine. So the cause of hemolytic anemia would like to the hepatitis mainly.
Okay, so hepatitis can lead to high colored urine. That is one thing. But again, their yellowness of eyes will also become an important symptom, which is not there in your case. Okay. Then what other causes can lead to high colored urine? Suddenly a child is developing that.
Any history of drug intake we should rule out. So
For which disorder? G6PD deficiency can lead to sudden onset anemia and high colored urine. Good. What else?
I would like to ask about history of blood.
No, high colored urine. I'm still there. High colored urine. Which condition will lead to anemia and high colored urine? We are still there. PNH is a rare disorder, very rare disorder, but it can cause, usually it's a chronic disorder with intermittent history of hemoglobinuria. So rare, but yes, it can happen. I cannot say wrong, so it is correct. What else? Common problems which can lead to this.
Any mismatched blood transfusion?
So there is no history of mismatched blood transfusion, but yes. No history. What else? Hemolytic uremic syndrome. Is there high colored urine? What is the classical triad of hemolytic uremic syndrome? Triad of HUS. Anemia, thrombocytopenia, uremia. What is TTP? Pentad. So two more things, neurological symptoms and fever. Okay. So high colored urine usually is not very common in HUS. Can be there if there is sudden severe hemolysis. What is another common reason where you develop sudden hemolysis, sudden pallor, and you can have high colored urine? G6PD you said, one is correct. What is the other one? Autoimmune hemolytic anemia.
That's right.
That is what we wanted to
That
ask.
is what we wanted to ask. Autoimmune hemolytic anemia we can present like this.
There is an entity called paroxysmal cold hemoglobinuria, PCH. This is common in children. They develop a viral infection and then 4 or 5 days later they have sudden hemolysis, massive hemoglobinuria. Generally it is a self-limiting disease. Okay, it's a type of autoimmune hemolytic. Plus other common hemolytic anemias, autoimmune hemolytic like warm and cold, they also can lead to this high colored urine. So, okay, so you have asked all that. There is no such history. So we go back to our case where we are discussing pallor and fatigability in 15 days history. Negative history, other negative history.
There is no history of any rashes in the sense of the petechia, purpura, or echosis.
Okay.
So for this, I would like to rule out any like ongoing bleeding.
So you are trying to look at platelet involvement or coagulopathy in this child where there is one cell line involved. And then what else will be the third important history? History of fever. Okay? If you have history of fever, if you have history of bruises, if you have history of anemia, then you know that all your 3 cell lines are involved. Okay? So what does this indicate? That the patient may be neutropenic. Because if there is neutropenia, then fever or opportunistic infections happen, and then all your 3 cell lines are involved. That means your marrow, you are dealing with a marrow disorder. So here in this case, you did not get any of those 2 other history. What other history did you ask? Quickly you can tell.
Any history of blood transfusion? Any history of any limb pain or limb swelling? Any history of any convulsions? Any history of headache or dizziness or any symptom?
Why did you ask the history of joint swelling?
Sir, anemia is there and with easy fatigability. That's why I would like to rule out the rheumatological causes so that in
Which rheumatic group?
the juvenile idiopathic arthritis.
That is what you see the pediatrician make a mistake. Juvenile rheumatoid arthritis, you have to have 6 weeks of time.
6 weeks of time.
It is only for few days.
2 days.
So don't mention when you are examining in the exam, don't say JE.
Rheumatology.
Say you can say non-specific arthritis, but don't say JE. Okay. That is very important. What word you are using? JE has to be 6 weeks of joint pain, not before that.
So with this brief history, the parents consulted a nearby practitioner, made the advice some of blood test. As the blood reports for abnormal, child was referred to the IS. Coming to the past history, there is nothing significant. There is no history of any blood transfusion in the past. There is no history of any tuberculosis or any chronic illness in the past, like in the tuberculosis or yes. With the family history, the child was born to the non-consanguineous couple.
I think we have seen that. Relevant only.
Tell relevant history.
So it is only 45 minutes we have to discuss so many things.
But
Is
this
it
is nothing significant developmental, is nothing
No, no.
significant immunization. And on general physical examination. A 14-year-old boy who is well built, well nourished, while I was examining, he was comfortably sitting on the bed, and on examination, temperature was 85. And
So in the, sorry, just going back, in the treatment history, did you get anything significant?
no histopathia, apart from analysis, he didn't take anything.
Any other investigations that were done significant?
So, only like if they told the CBC, the blood test, it was showing like abnormal counts, then they referred to the eye exam.
So no other big investigations were done.
Sir, it's a very common scenario that people tend to get some investigation from outside, and they probably know the normal diagnosis. Like in this case, which someone said, like this child has probably has leukemia. So we mentioned this in your history, like the child was involved, like the investigation was.
I don't think you say leukemia. You can only say that outside doctors inform that there is some serious illness. There is some serious illness in the blood, so they refer them to a higher center. That's a simple way of mentioning. Okay? Don't give the clear leukemia as a because it is not clear by the history. There is not even a bone marrow is done here. There is only history of pallor. So don't get biased. Just say that the doctor said there is some serious illness and they referred you to a higher center. Just simple. Then we will see whether we get towards there or not. See, if there is leukemia, but I don't know by history I can call this leukemia. By history of fatigability anemia, I am not going to call it leukemia just by history. So keep an open mind for this case. Don't give a biased diagnosis just because you had a diagnosis. This may be nutritional anemia. The child had a viral infection. The child had already existing nutritional anemia. 15 days he was not eating. It looks little worse. And then you are evaluating for a nutritional B12 iron deficiency. At the moment, I can't call it leukemia at all. So keep an unbiased mind because you don't really have any pointers towards that. Anna sir, what do you think?
I think अभी बाद में बात करें leukemia has got protein manifestations. तो कभी भी ये नहीं कह सकते उसको जॉइंट पेन भी हो सकती है, उसको फीवर चल सकता है, उसको न्यूरोलॉजिकल सिम्टम्स भी हो सकते हैं. The patient can present with paralysis, but don't say that कि वो leukemia का है. ये प्रॉब्लम पता कहाँ आती है? अब मुझे एकदम याद आया डॉक्टर आम लेकर होते थे. It is always good वो कहते थे एक बच्चा एक काऊ पड़ी है, एक काऊ को अगर एक MBBS ने देखा तो यार काऊ है, एक MD ने देखा तो यार कोई हाइब्रिड सा लग रहा है, काऊ भी लग रही है, थोड़ा सा ये भी लग रहा है. And when you go higher, super specialized, फिर वो अपनी जेनेटिक्स बताएगा, ठीक है ना. Now इसमें प्रॉब्लम इसकी नहीं है. This fellow is an FNB working in the Rajiv. He is registered with us. He is seeing a lot of cases of leukemia. अब वो leukemia की तरफ ही चल रहा है वो. So don't go. Try to be open mind, as Dr. Kalra said. तो ये नहीं आएगा कि जितना ऊपर चढ़ते जाओगे फिर कहेगा यार ये हाइब्रिड लगता है, आधा ये लगता है, इसे जेनेटिक एनालिसिस कराना पड़ेगा, ये कराना. सीधा सीधा है यार, क्या है उसकी हिस्ट्री लाइक. You people in the MD exam also will be asked not किसी को ना बात पता क्या होता है एग्जाम में, मैंने बहुत एग्जाम करा है, वो जाती अनुष्का देखिए कोई लीविया का पेशेंट पड़ा है, वो अंदर जाके ना और गड़बड़ हो जाती है.
तुम्हारा माइंड चल
वो जाके ना अंदर जाके वो leukemia ही शुरू हो जाता है. अरे भैया don't do that. Try to keep an open mind and try to present like this. Okay, that is the kunji for the exam. ये तो उसको पता लग जाएगा एग्जाम में. अच्छा यार ये leukemia भी पता कर लिया तो हिस्ट्री में. You don't do that.
So by history, this case is only 15 days of anemia, and that too appears a little sudden, not like a chronic anemia, not requiring regular transfusion, not requiring any other intervention. So short history of anemia. So now we have to think of DDs for that and move further. Okay.
On general physical examination, a 14-year-old boy who is well built, well nourished, comfortably was sitting on the bed. And on examination, temperature was equilibrium with the tachycardia with a pulse rate of 120 beats per minute, good volume pulse and normal rhythm, no radial or no radial hemorrhage. And the blood pressure was 120 by 90 mm of mercury in the right upper arm, which is more than 95%. and respiratory rate is of about 20 cycles per minute and saturation of 98%. And anthropometry, the present weight of the child is 54.3 kg, which is between the 50th to 75th percentile as per the IIP brochure. And the height of the child is 160 centimeter, and which is also between 50 to 75th percentile as per the IIP chart. And the BMI of the child is 21. On head-to-toe examination,
Anthropometrically बच्चा ठीक है,
yes.
not physical right नहीं है.
On head-to-toe examination, the child was looking pale, which can be seen in the lower palpebral conjunctiva, which is seen in the nails, which is seen in the pale, which is with the pale tongue, and with the disappearance of markers, with the pale markers. And there was no impress or any no clubbing, and no any cyanosis, and there is a bilateral lymphatic cervical lymphadenopathy. Right-sided cervical lymph nodes are more enlarged than the left side at the multiple levels, with the maximum size of 1.5 into 1.5 centimeter, which are non-tender, non-mobile, no redness, and non-conglomerate, and there is no signs of any infection of the lymph nodes. There is no axillary lymphadenopathy, there is no any significant inguinal lymphadenopathy, and there is no any hyperpigmented patches all over the body. There are no any birthmarks, and there are no any rashes or petechial purpura echinosis, as we are dealing with anemias. And testis of the child is within the TANF 4, with the bilateral testis, which is equivalent size. As we are dealing with the generalized weakness with the pallor and with the cervical lymphadenopathy, I would like to do the per abdomen examination.
Just 1 second. Now you are dealing with a child with anemia. Okay. So did you comment that there is no platinacchia in this patient?
Names were normal, only the looking for pain.
So you mentioned that.
Platinacchia.
So you should mention. Did you mention any knuckle hyperpigmentation?
No,
Is that important for a child with anemia?
it's a 14-year-old child,
Yeah.
but unlikely that they will have hyperpigmented knuckles with the vitamin B12.
It can happen. It can happen. It can happen. Okay, what else? So if there was knuckle hyperpigmentation, what will it point to?
Vitamin B12 deficiency, anemia, megaloblastic.
If there was platinacchia, what will it point to?
Any iron deficiency anemias, then any related bone marrow failure syndromes.
Bone marrow failure syndrome. Okay, now you bring me to bone marrow failure syndrome. Can you name a few bone marrow failure syndromes? Fanconi, okay.
Fanconi, dyskeratosis congenita.
Dyskeratosis congenita.
CDA.
CDA is not a inherited bone marrow failure. CDA is not an inherited bone marrow failure. Diamond black fan syndrome, okay. Diamond Pearson syndrome, okay. So if it is a child with DKC, sir pointed towards 14 saal. If it is DKC, what abnormalities will you find?
They will have hyperpigmented patches.
They will have hyperpigmentation of the skin. What else?
And there is leukoplakia.
Leukoplakia, so their tongue will have patches. Nail changes. This keratosis will be there, so nail changes will be there. Very typical. Tongue will be abnormal, nail changes will be there, skin pigmentation will be there, premature graying of hair can be there. So if you identify these problems in a child with anemia or thrombocytopenia, think of DKC. Can you name some features of Fanconi anemia?
These typically usually present with a short stature.
Short stature.
Abnormalities, mainly more than 50% of the children will have abnormality like bifid thumb, tripharyngeal thumb.
Tripharyngeal thumb, bifid thumb, yes.
And they will have
What else?
they have endocrine abnormalities in the sense of the growth hormone deficiency, short stature, hypothyroidism, they have glucose intolerance, and they can also have hypogonadism.
So they will have may have mental retardation, growth failure, hyperpigmentation of the skin. They may have capsular spot, they may have kidney, heart abnormalities, they may have visual problems, hearing defects, they will have typical triangular facies. Don't forget that. And other siblings also in the family can have. So any child who comes with anemia, especially long-standing with growth failure, think about these things. So in this case, we did not find that. We were talking about platinikia. He only took me to inherited bone marrow failure. I was not going to inherited bone marrow failure in this case. But anyway, so you looked at other causes of anemia in this patient and you will want to evaluate that. Schwab diamond is another one which has severe neutropenia in childhood, pancreatic abnormalities, they will have typical facies, growth failure, they will develop aplastic anemia or they can develop AMN. All these children who have inherited marrow failure can also develop myeloid leukemia. You should know that. So transplant should be done for these patients. So okay, so coming back to our case, in the general physical examination, you found significant lymphadenopathy and you found anemia. So now we have moved forward from only anemia, we are now identifying lymphadenopathy also. So from this, we have got this much finding, and now he is going to do per abdomen examination.
Before the examination, I always say 85% of the time you can find out by a good history what I am dealing with. Now if I ask you, you have a good history, give me the differential. We always say you do the examination and then you cut off the leads. But first you have all the examination. After the good history, what is your differential? Give me the differential, then you go to the examination, then cut out few things, and then you say, I am dealing with this case. Now tell me by history what you have done with the negative history. What is your take on this child? Give me 1, 2, 3, 4.
With the history of generalized weakness, pale.
सब सुन लिया सब. Don't waste time.
बस नाम बता.
मेरे को सिर्फ नाम बता दे कि भैया एग्जाम में भी ऐसा नहीं होता दोबारा शुरू हो जाएगा उससे कोई फर्क नहीं. You give me 1, 2, 3, 4. What is your differential diagnosis with this history? With your negative history, tell me what are you thinking about? एक दो तीन बताओ. मैं नोट करता हूँ यहाँ पे.
Acute viral infection.
Acute viral infection. Okay. Points in favor?
Points in favor is acute short history of short duration, and there is a pallor and there is a lymphadenopathy.
What are the points against?
Fever is not long standing, fever is not high grade. Like it's
That is
not
overall. Easy fatigability नहीं चल रही है, parallel हो रहा है, पता नहीं parallel हो गया. Unlike this is not with the viral infection. Fever चल रहा है, ठीक है, उसको जनरलाइज एक सो रहे हैं. इतनी जल्दी उसको ये नहीं होगा. चलो acute viral infection तेरा पहला diagnosis है. Now I am writing down first diagnosis acute viral infection. Second diagnosis nutrition. Okay. What are the points in favor? Have you taken any dietary history of this child?
some child is
बच्चा है 50 to 75th percentile पे चल रहा है. बच्चे को तो लेने का सोच रहा है. वेजिटेरियन और नॉन वेजिटेरियन. नॉन वेजिटेरियन है. अच्छा. और एग्जाम
नॉन वेजिटेरियन कितने हफ्ते में कितनी बार नॉन वेज खाता है?
ये सारी चीजें बहुत इम्पोर्टेंट होती है.
सी इंडिया में नॉन वेजिटेरियन ना महीने में एक बार अगर नॉन वेज खा रहा है तो वो प्रैक्टिकली वेजिटेरियन ही है. तभी तो 70 से 80% लोगों को
नॉन वेजिटेरियन
है ना. तो you have to know how much he eats twice a day, once a day at least he eats, then that is like real non-vegetarian.
Second diagnosis of his is nutritional anemia. क्योंकि इसके points in favor कुछ नहीं है. इसने कुछ नहीं बताया. वेट अच्छा है उसका. कोई फेवरेट थ्राइव नहीं है. नॉन वेज खाता है. उसके बाद में कोई उसको क्लिनिकली उसको कुछ नहीं मिला है ना. ठीक है. What is your third diagnosis?
I don't have any third diagnosis.
You don't have any third diagnosis.
Because this is not
Why can't you leukemia? Why are you hiding leukemia? No, because I am asking. He's not saying leukemia. Because otherwise I am fired. Leukemia बोल दिया तुमने. अरे भैया, अगर बच्चे को 15 दिन का बुखार है, फीवर हो रहा है, इजी फैटिगेबिलिटी हो रही है, फीवर आ रहा है, it could be leukemia also. And as I said at the outset, leukemia can have a protein manifestation. Why not be leukemia? Why are you hiding leukemia?
Can you name one viral infection which can present with anemia, fatigability, lymphadenopathy? Very important in this age group. So it can be infectious mononucleosis like picture. Keep that in your mind. Okay. If it is infectious mononucleosis, how do you investigate? What do you find?
Usually on examination throat will be more congested and then there will be multiple exotic lymph at the cervical and axillary and there will be the organomegaly and
What organomegaly?
hepatosplenomegaly.
Splenomegaly is typical. What else? And then on investigation you will find dash in the peripheral smear.
So
Atypical lymphocytes in the peripheral smear. Okay, they are typical. There is some typical description of those lymphocytes that you find in EBV infection. So this much you should know, especially this age group. Infectious mononucleosis is common. Okay, other names for infectious mononucleosis and kissing disease. पता है, बाकी और नहीं पता. Glandular fever. Is glandular fever another name for infectious mononucleosis? What type of virus is EBV? चल, ये सब भी पढ़ना है, ठीक है? You need to know EBV. Let's move forward. Move forward.
And on exam inspection, the shape of the abdomen is normal, umbilicus is centrally umbilicus is normal, and there is no abdominal distension, skin over the abdomen is normal, and there is no dilated or any involvement. And on palpation, there is no tenderness, and the abdomen is soft, non-tender, and there is a hepatomegaly, that is a liver 4 centimeter below the right costal margin, which is soft, non-tender, and margins are well fed. And there is a splenomegaly, which is up about 3 centimeter from the below the left costal margin, which is soft and non-tender. For abdomen percussion not done and auscultation.
Sorry, positive finding in abdomen.
Hepatosplenomegaly.
How much liver?
Liver is 4 centimeter below the right costal margin and it is 3 centimeter below the left.
So there is significant hepatosplenomegaly. Next one. CVS, CNS are
it is not.
no, all not. Tests you have already mentioned. Okay, why you think I am specifically asking about tests here?
Testicular involvement indicates a high risk spore prognosis for the
बेटा पहले ही बोलो testicular involvement means it can be leukemia. So what is the clinical feature of testicular leukemia? क्या होगा? Testis कैसी होगी? Painful, red, inflamed, enlarged. It's painless. Okay, painless testicular, generally asymmetrical. Maybe one testis is enlarged. It will be painless. So very important in a child with leukemia that you have to examine. Okay, child. Suppose this child hepatosplenomegaly, pallor, bruises, has got a facial palsy. What does it mean? If this child has a facial palsy, madam बताओ क्या होगा इसका मतलब? बोलो. If this child has facial palsy, इसका क्या मतलब है? आप बताओ जी. आप बताओ. CNS involvement of leukemia. If this child has a facial palsy, मतलब leukemia brain में भी गया हुआ है. Okay? If you see leukemia in a patient or suspect leukemia in a patient with a neurological manifestation, immediately आपको suspect करना है जिसको हो सकता है CNS में involvement. अब ऐसे बहुत सारे बच्चे जिनको joint pains होते हैं, joint swelling होती है, वो steroid खाते रहते हैं. क्यों? क्योंकि उनको JIA सोच लिया. बच्चे को फेशियल पॉल्सी हुई, उसको बेल्स पॉल्सी समझ के स्टीरॉइड दे दिया, बाद में पता चला उसको ल्यूकीमिया था. पैरापेरेसिस हुआ, स्टीरॉइड दे दिया, बाद में पता चला ल्यूकीमिया था. तो स्टीरॉइड इज अ वेरी बिग ड्रग. डोंट यूज इट कैजुअली. ब्लड चढ़ाने से पहले एफकॉर्लिन लगा दिया. नो, it should never be done. So you all have to learn this. Giving steroid quickly melts away leukemia and your diagnosis will be delayed. And then the cancer will come back later, and when the cancer comes back later, it will come back stronger.
Okay, so never give steroids in an undiagnosed condition. Okay, so you know all these findings. So if you have hepatosplenomegaly, lymphadenopathy, anemia, how will you investigate this child?
First, I would like to do the complete blood count with the pestilence smear and the reticulocyte count. With the complete blood count, they can be anemia, bicytopenia, thrombocytopenia. As leukemia, based on these, CBC, we will move on to further test.
So very important, आप जब भी किसी बच्चे का CBC ऑर्डर करो, आपको हीमोग्लोबिन देखना है, TLC देखना है, प्लेटलेट देखना है, और नेक्स्ट फोर्थ थिंग जो आपने देखी है वो देखना है न्यूट्रोफिल. Don't miss neutrophil. Most important cell that the bone marrow produces which saves your life is neutrophil. Don't miss neutrophil. अगर न्यूट्रोपीनिया है तो कुछ मेजर गड़बड़ है. Although viral infections में भी न्यूट्रोपीनिया आता है, but transient आता है और फिर ठीक हो जाता है. So if you document neutropenia, make sure that you document the recovery trend also. If there is isolated anemia, obviously all the RBC parameters become important. Now suppose I tell him that this child has hemoglobin of 5, has TLC of 2000, has platelet count of 30,000. What do you call this situation as? Pancytopenia. Suppose I say hemoglobin is 5, TLC is 6,000, platelet count is 40,000. What is this? Wrong. Wrong. Pancytopenia, bicytopenia बोलने के लिए it is not TLC, it is the neutropenia. मैंने तो आपको न्यूट्रोफिल बताया ही नहीं. क्या पता 6000 में 2% न्यूट्रोफिल हो तो क्या बन गया वो? Pancytopenia बन गया ना. तो bicytopenia, pancytopenia, always not by TLC. You have to look by neutrophil count. Okay, very important. समझ लो इस बच्चे को पैनसाइटोपिनिया, और मैं नेक्स्ट स्टेप में आपको बोलता हूँ अब आप क्या करोगे?
I would like to do the bone marrow.
Wrong.
Like I will
I will look at RBC indices and peripheral smear. Next step is RBC indices, peripheral smear, retic count. अब मैं आपको केस बताता हूँ. यही बच्चा, इसका RBC indices के अंदर आया MCV 120, RDW 24, RBC count 2.3. अब आपका क्या likely diagnosis है? तो most likely ये macrocytic anemia है with high RDW, with low RBC count. Go back, take nutritional history. बच्चा खाता ही नहीं है. 14 साल की लड़की अच्छे से खाना नहीं खाती, सिर्फ मोमोज चाउमीन खाती है, तो क्या होगा? B12 folic acid deficiency, does not drink milk, does not eat cheese, does not eat non-vegetarian, only junk food as most likely. So pancytopenia जब आप डिस्कस करते हो, सबसे पहले कॉमन कॉज इंडिया के अंदर मेगालोब्लास्टिक एनीमिया रूल आउट करना चाहिए. ठीक है, वेरी इंपॉर्टेंट. इन्फेक्शन से भी पैनसाइटोपिनिया हो सकता है, डेंगू से भी हो सकता है, टाइफाइड से भी हो सकता है. तो कॉमन इन्फेक्शंस की इन्वेस्टिगेशन करो, जैसे डेंगू सीजन में डेंगू टेस्ट करो, ब्लड कल्चर करो, बेसिक इन्वेस्टिगेशन करो. ये सब कुछ आपका नॉर्मल आ रहा है, पेरिफेरल स्मीयर में ब्लास्ट नहीं है. अब आप आगे क्या करो?
I would like to do the bone marrow examination and
To rule out?
to rule out the marrow fibrosis, bone marrow aspiration and biopsy. I would like to do.
To rule out what you want malignancy. मैं कहता हूँ जी नहीं, ये malignancy नहीं है. मैं कहता हूँ ये तो aplastic anemia है. तूने क्यों malignancy बोला? तुझे diagnosis पता है, गलत. बोलो.
Points against.
Points
में तुमने देखा.
What is the point against? My question is that we are evaluating pancytopenia child. I said you are doing bone marrow. I said why are you doing marrow? You said I'm doing it to rule out malignancy. I said you are biased. This is aplastic anemia. This is not malignancy. Points favor, points against.
points
You don't see this in aplastic anemia. Simple. Sir, मैंने malignancy इसलिए बोला. ठीक है ना?
ऐसे सवाल बताने पड़ेंगे.
Okay, clear. So now you are approaching a child with lymphadenopathy, organomegaly, anemia, and now you're done with CBC smear, you've ruled out common problems, you've ruled out infections, EBV भी नहीं लग रहा आपको, और अब आपको आगे बढ़ना है, तो अब आपने कहा बोन मैरो करना है, अब बोन मैरो में आप क्या करोगे और क्यों करोगे बताओ?
Bone marrow, I would like to do the aspiration and the biopsy. Aspiration is mainly for the cell, morphology, and as fibrosis is mainly for the biopsy is mainly for the fibrosis.
So biopsy का main purpose क्या होता है? Biopsy का main purpose is cellularity, not fibrosis. बच्चों में fibrosis नहीं होता, बड़ों में myelofibrosis होता है. बच्चों में आप cellularity देखना चाहते हैं. Also आप कहोगे जी अगर हम बैठे हैं अपने हॉस्पिटल में, सर यहाँ बैठे हैं, मैं गंगाराम में बैठा हूँ, अगर एक अच्छा बोन मैरो एस्पिरेट किया और अच्छा सैंपल भेजा और उसमें फ्लो साइटोमेट्री सब टेस्ट करे, आप ल्यूकीमिया का डायग्नोसिस बनाते हो, हमें बायोप्सी की जरूरत नहीं होती, बट हम फिर भी बायोप्सी साथ में इसलिए करते हैं क्योंकि बच्चे को एक बार सेडेट किया, अक्सर बच्चों को पैनसाइटोपिनिया, you are not sure whether it is leukemia, aplastic anemia, other condition. So might as well do both the procedures in the same go because you have sedated the patient. You don't want to go back again. So generally we do two things together, but truly speaking, to make a diagnosis of leukemia, only bone marrow aspirate with good sampling is enough. Now you did a bone marrow. What can be the findings in the bone marrow for a patient with leukemia?
There can be decreased number of the RBCs, RBCs usually will be the normal cell. First and foremost thing is the lymphoblast. You can see.
So wrong. Wrong. You should say blast. You can't say lymphoblast. It can be myeloblast. So what will bone marrow have in a patient with leukemia? There will be abnormal proliferation of cells, which are blast cells. They can either be lymphoblast or they can be myeloblast. In adults, they can be many other types also. But children, commonly you have lymphoblast or myeloblast. Now you have to differentiate between lymphoblast and myeloblast. How will you differentiate? Is it important, Dr. Jeevan, to differentiate why? Blast ही तो है.
Further investigations के further investigations के लिए आपके इसके अंदर प्रोग्नोसिस है.
ट्रीटमेंट बिल्कुल अलग है. AML ALL ट्रीटमेंट बिल्कुल अलग है. AML ALL प्रोग्नोसिस अलग है. तो इसलिए you need to characterize. So you put some special stains and you differentiate. Can you name 2-3 stains quickly? PAS staining, MPO staining, myeloperoxidase, PAS staining. They have to differentiate between ALL, AML, plus the morphology. Okay, so read about that. You don't have time, but you read about morphology of blast. Okay, then what's the next step?
After confirming the diagnosis,
5 minutes.
to find out whether it is a BALL or like a T lymphoid or B lymphoid, I would like to do the flow cytometry or the next.
Or to find out AML. Don't get biased by the AML. It can be AML. Then you do what is the next step? Flow cytometry. So immunophenotyping. Okay. So every cancer cell has got some markers. So you do immunophenotyping to find out what are the markers on the cells. B cell ALL has different markers. Can you name 2-3 quickly?
19, 20, 22, 79, and 10.
Very good. 19, 10, 20, 22. These are 79. These are
B cell.
B cell. What are T cell markers?
CD3, CD4, CD5.
3, 7, 4, 8. These are T cell markers. Myeloid markers?
13, 33, 117.
13, 33 are common myeloid markers. Very good. So you do immunophenotyping. So after immunophenotyping, what other tests you do?
I would like to do the molecular analysis, and I would like to do the karyotyping.
Karyotyping and molecular analysis. Can you name a few markers that you will find in molecular and karyotyping?
Translocation 190, 1221, KMT like 922.
922. Philadelphia chromosome. 922. Name a drug for that? Imatinib. Okay, so it changed the whole leukemia scene in the world. So ये common questions हैं आपसे पूछे जाएंगे. So you do karyotype, molecular. ओके, आपने ये सारा टेस्टिंग कर लिया, व्हाट इज द नेक्स्ट स्टेप?
After confirming the diagnosis, I would like to explain the parents about.
No, so you do a lumbar puncture to find out CNS involvement or not. Okay, you do a lumbar puncture, so you have done all that, CNS negative है, अभी next step में आप क्या करोगे? अब आपको पेरेंट को काउंसिल करना है, बच्चे को B सेल ALL आया, आपको पेरेंट को काउंसिल करना है कि इसका इलाज कितना लंबा होगा और आउटकम क्या है। आप ऑन्कोलॉजिस्ट नहीं हो, हम तो आपसे बेसिक चीजें पूछेंगे, तो आप बताओ 2-3 कप सवाल बस। What is the outcome of B cell ALL?
More than 90%.
More than 80% क्योर रेट। आप हाइपरटेंशन क्योर नहीं कर सकते, आप डायबिटीज क्योर नहीं कर सकते, मगर आप कैंसर क्योर कर सकते हो। तो आपको होप देनी है पेशेंट को, आपको उनको बताना है that you can cure childhood cancer. ओके, सो पीडियाट्रिशियन की बहुत बड़ी रिस्पॉन्सिबिलिटी है। आप पेशेंट को रिएश्योर करके भेजोगे, घबराओ मत, इस हॉस्पिटल में जाओ, आप ठीक हो जाओगे, देन ओनली दे विल गेट द चांस। ओके, एंड ट्रीटमेंट ड्यूरेशन बताओ, around 2 to 2.5 years. Okay, so this is broadly we will tell you. So broadly this is how you treat ALL. Also very important thing is we want to tell you about risk stratification. So हर ल्यूकीमिया को हम एक तरीके से ट्रीट नहीं करते। जैसे कहते हैं, हम कैसे समझाते हैं पेरेंट्स को, एक बुरा राक्षस है, एक बहुत बुरा राक्षस है, और एक उन सब का भी बाप है। तो एक बुरा राक्षस होगा, आप एक गोली चलाओगे मर जाएगा, बहुत बुरा राक्षस है, आपको शायद 10 गोलियां चलानी पड़ेगी, और बहुत बुरा वाला राक्षस है तो आपको हो सकता है तोप चलानी पड़ेगी। ऐसे ही ल्यूकीमिया के भी टाइप्स है। So we do risk stratification. We try to identify standard risk, high risk or very high risk leukemia, and our treatment intensity depends on that. How do you risk stratify? We have lack of time. Quickly I will tell you. So first is age. In ALL, 1 to 10 years is good. Less than 1 or more than 10 is little bad. B versus T में B is better. Okay, CNS negative positive में negative is better. White cell count में if your cancer diagnosis is with white cell count less than 50,000 it is good. Okay, तो ये basic आपके हो गए। ठीक है, पहले कहते थे कि girls में better है than boys, but nowadays we find both do equally okay. Then further by karyotyping molecular we can find out the risk. So if you have hyperdiploidy in karyotype it is good. If you have BCR-ABL it is little bad. If you have MLL gene rearrangement it is little bad. If you have 12-21 translocation which is 10 AML it is ETV rungs 1 it is good. Okay, तो ये कुछ parameters हैं, अगर आप याद करोगे एग्जाम में बोलोगे doctors will be happy. Most important prognostic factor is your response to treatment. आपने कीमोथेरेपी दी, 1 महीने के बाद बोन मैरो किया, और बोन मैरो में आपका कैंसर रेमिशन में आया, और ये आपका MRD measurable residual disease नेगेटिव आया, तो your chance of curing leukemia is very very good. Okay, so basic risk stratification, and based on the risk stratification we give the intensity of treatment. So give hope to the children and be positive, manage these children with good passion, and you can have good cure. This is also September, which is Childhood Cancer Awareness Month. We are everywhere, we are spreading the message that childhood cancer is curable, and if young pediatricians know that, then our job is done. Okay, thank you.
So last but not the least, I have brought this case from Kalra. It's a riddle. You have listened to him. He has explained to you everything. This is a child who was treated in January. He was treated for ALL. And now you see the child, he is on maintenance therapy. अभी बताया उसने कि 2 साल लगते हैं। उसमें जो मेन दवाई दी जाती है मेंटेनेंस थेरेपी में, वो दी जाती है methotrexate, which is weekly, and mercaptopurine every day. Right? Which is this child is on. Now I will give you some question. Last but not the least. ये बच्चा 4 साल का है। The initial TLC of this child was 1,24,000. Okay, दिस चाइल्ड हैड हेपेटाइटिस था, डायग्नोज हो गया, ये बच्चा बी सेल ALL डायग्नोज हुआ, ठीक है। द चाइल्ड इज काला पॉजिटिव है, CNS नेगेटिव है, उसका LP हुआ, LP नॉर्मल था, ठीक है। तो उसमें कोई ब्लास्ट हमें नहीं मिले। अब ये बच्चे को आप रिस्क स्ट्रेटिफिकेशन से आप क्या बोलोगे? 4 साल का बच्चा, 1,40,000 उसका काउंट, ठीक है, और उसको B सेल ALL है, और जो मॉलिक्यूलर में 922 नहीं है उसको। तो इसको आप कोई बताए कि ये यौन कर रही है, इसको पूछता हूँ सबसे पहले, ये तू बता मेरे को कि ये कौन सा रिस्क है इसका? 4 साल की बच्ची है, स्टैंडर्ड रिस्क, CNS ल्यूकीमिया नहीं है, और B सेल ALL है, अच्छा है, तो बट स्टिल दिस चाइल्ड वाज ट्रीटेड एज इंटरमीडिएट। पास हो गए सब लोग, वेरी गुड, थैंक यू वेरी मच।
Thank you so much.
नहीं आप निकलोगे, लेकिन हम आपको एक फैसिलिटेट करेंगे सर।